Thank you so much. Appreciate it. Assalamu alaikum wa rahmatullahi wa barakatuh جميعا. Thank you for the organizing committee for accommodating the flat tire. Allah, it's disastrous a bit, but it's fine. So I'm only asking 1 or 2 maximum ATPs. I know it's the end of the day, just to follow up with me. So most of the audience in the room would know that TTP basically is a deadly disease. I don't know why it is being labeled worldwide as a benign condition. It has a high mortality rate from more than 90%. With a single intervention like therapeutic plasma exchange, it can go down to 20%. This is a miraculous thing that happened back in 1991. So important dates in Saudi Arabia that I would like you to follow up with me. So in 2012 was the first robust guideline from the British Society of Hematology published regarding how to manage TTP. In 2015, how most of the investigators did agree that ADAM-TS30 testing became available in Saudi Arabia and we can order it. In 2019, the Hercules trial, which came subsequently after the Titan trial in 2017, was a phase 3 randomized clinical trial, giving us more evidence to use caplacizumab. In 2022 was actually our first Saudi guideline published in Journal of Applied Hematology of how to manage acquired TTP. So my main objective was basically, or the whole group objective was actually, what's the TTP status in KSA? So we go, are we diagnosing or referring early? Are we sending the appropriate test? And are we following the published guidelines? So for the methods, we asked each center from inception to get us all patients with presumed diagnosis of TTP who underwent therapeutic plasma exchange. This actually idea came to my mind when actually we attended the first physical conference after the COVID era back in Jeddah. We sent messages around, emails, hello, to 22, 23 centers across the country, and we were lucky actually to have 6 apheresis centers actually responding to us. So we had digital communications. We never met on one table, but alhamdulillah we have Zoom. So we went through all the registries, tried to figure out which data to collect from each center. We had so many obstacles, including the heterogeneous of the data, like you can imagine that cutoff for LDH, the values or units used for creatinine, for example. So for the results, we were, alhamdulillah, we were able to collect 112 patients. Some centers actually even went back to 1995 to diagnose TTP. Numbers available for analysis were only 100. Demographic were consistent with the global data, age between 20 to 40, female definitely more than male, as an autoimmune condition, underlying malignancy, an autoimmune disorder, personal or a strong family history. The clinical presentation, fever, neurological abnormalities and renal abnormalities, and even the complete pentad, which we classically teach the medical students, was actually only present in 4%, which is consistent with the new ASH education book actually, they published 7% or 8%. Laboratory results, definitely low platelets, high creatinine, and high LDH indicating hemolysis, but we were focusing mainly on the ADAM-TS13. And the level was actually only sent for out of 100 for 48 patients. To diagnose, you need less than 10%, and it was only positive in 37 patients. Reminding you, these were all cases of presumed TTP. Also, anti-ADAM-TS13, out of our surprise, was actually only ordered for 26 patients. So we have a little bit of deficiency in how to order ADAM-TS13. Where the clinical scores applicable? Well, there are 3 published validated clinical scores, the Bentley score, the French, and the Plasmic score from Harvard. They were all applicable, alhamdulillah. We were doing a good job whenever we see or manage a patient with TTP. The French score was 60% only because we were not sending ANA, which is a screening for autoimmune testing. As a management outcomes, we looked at how many sessions the patients would get, what's the time from the patient get the diagnosis till we hook the machine for the apheresis. Internationally, it is recommended to happen maximum in 8 hours. Unfortunately, in the country, we are lagging behind, like 2.5 days for the patient since diagnosis to get an apheresis done. I'd like to also bring your attention, the mortality rate was 25% down in the slide, which is consistent, like almost 20%, and we only used caplacizumab once for our patient, for the 100 cohort patients. Reminding you 2019 when actually the Hercules trial was published. Where we would like to go from there, so confirming the diagnosis of TTP, this is the main message. We are doing a good job in suspecting the diagnosis of TTP. We teach our medical student, medical technology. Whenever you see schistocytes or blood fragment, just raise your hand and shout out. But how to confirm it, access to a referral center who actually can do apheresis, access to monoclonal antibodies, including rituximab and caplacizumab, sending clinical pathways, and even the way to follow up. We were, alhamdulillah, happy to get this published 3 months ago in the Journal of Clinical Apheresis, which is the home for the ASFA guidelines, the American Society for Apheresis. Where we'd like to go from there, either TMA hotline, we need a physician on the other side, as on call, or sending clinical pathways across the country, or even, inshallah, we're aiming for is a national registry for TMAs, thrombotic microangiopathy. I really would like to thank my colleagues from King Abdulaziz, King Saud, King Fahd Armed Forces Hospital Jeddah, and King Faisal Special Hospital in Dammam, National Guard in Riyadh, and King Khalid University from Abha. Thank you so much.